All right, well, thank you everybody for joining us this week for the ultrasound lecture series and for just kind of being a part of this forum, just reflecting on that recently. And it's been a good opportunity just to learn about ultrasound and kind of see ultrasound from a bunch of different perspectives, whether it be from our own in the ED or from someone else in the unit, as we were talking about with Z here. But today we're going to have a little bit of a different conversation. We've invited Courtney Smalley, who is the director of ultrasound, Director of Point of Care Ultrasound over at the Cleveland Clinic, to come and talk to us today. And she's going to talk a little bit about an admin side of ultrasound, talking specifically about billing and coding. And this is something that's maybe not as clinically exciting in terms of finding the new effusion or different physiology, but certainly very, very important topic when it comes to program maintenance and management and kind of how we basically go from doing no ultrasound to having the equipment and resources to do lots of ultrasound. So with that being said, I'm going to turn things over to Courtney and look forward to hearing what you have to say to us today.
Great. Thanks, Matt. Very excited to talk to you guys today. As Matt pointed out, billing and coding may not be the fun side of ultrasound, but it is a very important part of our practice. And anybody who's a point of care ultrasound expert wants to make sure that their images are utilized in the clinical realm. And obviously, when we do things for patients, it's important that we document them and also get reimbursed for them. So as part of this lecture series, we're going to take this administrative turn and we're going to talk a little bit about what it means to bill for point of care ultrasound exams. So I'm going to give a disclaimer that I am by no means an expert in this. I learned much of this through my administrative role as I built the point of care ultrasound program at my current job. And so I learned a lot about billing and coding over the last 5 years. And now that ultrasound has expanded into so many other fields, and we're starting to see some of our primary care colleagues and some of our outpatient experts come into this world, there's a lot of nuances to this. So I'm going to try to answer some of the questions. I'm hoping that you guys can ask me questions that maybe I don't know the answer to as well, and maybe even expand some of the questions in my knowledge for things that I can build into our own program. So we'll take it away. Oh, and at any point, I can't see the chat. So if at any point somebody has a question, you can just chime in, or at the end, I'll pull up the chat and I'll try to answer questions individually as we go. So I have no disclosures. The objectives of this talk is to understand how to effectively code and bill for your point of care ultrasound exams. I'm going to talk a little bit about CPT codes and their modifiers. This is very important for what we do. I'm going to discuss the documentation requirements of a billable report. I'm going to distinguish between diagnostic and procedural point of care ultrasound billing, which has its nuances in itself. We're going to describe a little bit about what a limited exam is and what a complete exam is. Again, many people that practice point of care ultrasound know the clinical difference of this, but we're going to talk about it from a billing standpoint. And then I'm going to review kind of special questions, special circumstances, and maybe different questions amongst different specialties regarding point of care ultrasound billing. So let's start with the basics. So what is a CPT code? You likely are familiar with this term because everything that we do in medicine is associated with a CPT code. So a CPT code is called the Current Procedural Terminology Code. It was created as a language. You can almost think about it as like, like learning Spanish. This is a new language that was made to help standardize medical services and procedures and to increase the accuracy and the efficacy of documentation and billing in the world of medicine. There's 3 categories of CPT codes. The first category is a descriptor that corresponds to a procedure or service. The second category is a supplemental code for performance measure. And then the third category is basically something that encompasses anything that doesn't meet category 1. These were created by the American Medical Association, and all of the ultrasound codes that we're going to be talking today are in category 1. So we're not going to talk about anything in category 2 or category 3. So I wanted to give you a couple of examples as we start to talk through this, what this means. So on the left-hand side of the screen, I gave some examples of emergency ultrasound CPT codes. So these are many of the studies that we bill for in real time in the emergency department. All of these studies have a corresponding CPT code to them. So this ultrasound chest, I always get asked by our clinicians when they're doing lung ultrasound why the order is listed as ultrasound chest instead of ultrasound lung. And if you know the background behind billing and coding, the reason that we label our order as ultrasound chest is because the CPT code is listed as ultrasound chest. Other things we do in the emergency department, we do abdominal ultrasound, retroperitoneal, we do pregnant patients. There's a special CPT code for transvaginal ultrasound, pelvic ultrasound, pericardiocentesis. I gave two other examples here of different other specialties and some of the codes that they may use on a regular basis. So here is an example of CPT codes that likely could be used by ortho or MSK or PM&R physicians or practitioners who may be doing a lot of evaluation of joints, joint injections, needle placement, and procedures. And down here, I pulled some of the common CPT codes used in the intensive care unit for mostly resuscitative ultrasound. So our critical care colleagues are frequently doing echo and chest and many, many procedures. And so these are some of the CPT codes associated with those types of ultrasound exams in their department. So every CPT code can have a modifier to it, and this can get very complicated, but you should think about it, try to think about it as a little bit simple in what it really is meant to do. A modifier is really meant to give the coder and the biller an idea of different situations which may exist when you were doing the point of care ultrasound. So just a little bit higher than the modifier, one of the things I want to start talking about is the technical component and the professional component. And this, if you are building this within your community hospital or within a healthcare system, this is going to be an important part of how you can adequately reimburse and retain funds from your studies. So the technical component is the modifier that describes the actual use of the machine, the upkeep of the machine, and anything associated with the use of the machine in an environment. And this is going to look different on the inpatient side versus the outpatient side. As clinicians, the part that we are most familiar with is the professional component. And the professional component is the part where you, as a clinician, with your expertise and your medical training, can make an interpretation after you've acquired the images about what you see, and you can come up with a diagnosis or a report or some sort of interpretation based on the study you've performed. We're going to talk a little bit about mid-levels later on, because again, mid-levels in residence, it's a little bit different, but I just wanted to put this in here that mid-levels can report a global service code. So global service, physicians can do this as well. That's the professional component and the technical component combined. So depending on where you're employed or what type of environment you're working in, you may be able to bill what's called a global service code, which means that you're including both. So let me just kind of give you an example of some of the different CPT modifiers that many times are used in our point of care world. So this CPT modifier 26 is the professional component of the global fee. Almost all of us, when we do point of care ultrasound, will have this CPT modifier on whatever study we're performing. So for example, if you're doing a chest ultrasound to look for B lines, you would bill out the CPT code for ultrasound chest, a limited ultrasound chest, and this CPT modifier would be placed at the end of the billing code to demonstrate the professional component of what you have done. So this is the interpretation of your point of care ultrasound with a signed report. And we're going to talk a little bit about reporting later. There's a partially reduced service provided. The most common example for in the emergency medicine world would be this transvaginal ultrasound. This is a little bit more complicated. We're not going to talk about this too much because these codes are kind of done few and far between. Some of the more common codes, though, that you guys probably use and you don't realize when you're doing studies would be, for example, especially in a trauma hospital, would be the CPT modifier 59. So the best example for this would be if somebody comes in with like a shrapnel injury, right, for some reason, and they have multiple soft tissue foreign bodies in their legs and in their arms, and you do multiple different ultrasound exams. But the indication for the exam is the same, and it's the same type of CPT code. So you're doing a soft tissue ultrasound, but you're doing it in different areas of the body. This CPT modifier 59 would be added on. Something that we're very familiar with in the intensive care unit world and in the emergency medicine world are the CPT modifiers 76 and 77. So our patients tend to change their clinical status without maybe letting us know. So when a patient all of a sudden becomes hypotensive, you may repeat an exam. So the most common example of this in the emergency department would be a repeat fast exam. So a trauma patient comes in, they get their initial fast, the initial fast is negative. You're resuscitating them or doing a procedure, and then all of a sudden the patient changes their clinical status and becomes hypotensive, and you decide to do a repeat fast exam. So you can bill for that repeat exam with this CPT modifier 76. Now, if let's say there's been a shift change and your trauma patient changes their clinical status after 2 hours of being in the department, and the next physician comes in and repeats a fast exam, we would use this CPT modifier 77. In the ICU, this is kind of pretty common because as these intensive care unit patients maybe throughout the day can change their status, they get admitted to the ICU. Maybe the ICU physician does a quick cardiac ultrasound to assess their cardiac function, and then throughout the day something changes later in the evening. It may be the same clinician, it may be somebody else who does a repeat exam within that same 24-hour period. Again, that CPT modifier 76 or 77 would be added to the CPT code. So reimbursement. Let's talk a little bit about the professional fees and the technical fees, because this is something that confuses many people. So I think the concept behind a professional fee is actually fairly straightforward. It's really us being able to use our medical knowledge to interpret what we find. The technical fee is what it costs to maintain the equipment in the site that you are working in. So the way I kind of use this example is take out point of care ultrasound and limited ultrasound. Let's talk about how we send a patient to a CT scan to get a CTPE. Well, when the patient goes to get a CT scan, they are brought down to the CT suite. There is a tech there who's specialized in performing the correct CT with the correct timing of the contrast, getting the patient on the table, utilizing the CT scan and obtaining those images. Once those images are obtained, they optimize the images, they put them in a file, and then they push them to a work list. That would all be considered in the technical fee. Then the CT scan goes to the reading radiologist, and then the reading radiologist, who did not personally acquire those images, looks through those images and makes an interpretation based off of the images. Now, an example of this would be what happens if a patient goes to the CT scanner and the timing of the contrast isn't correct. So it doesn't necessarily push the contrast at the right time, or let's say the patient moves on the table. Do we take away the technical fee? No, because at the end of the day, we still need to pay for the upkeep of the CT scanner. We pay for the upkeep of the tech who runs the CT scanner, their training to be able to utilize that machine. And it's the same with ultrasound. Many times I'm asked by our clinicians, well, I went to the bedside, I attempted to do a cardiac ultrasound. I tried to obtain 4 views, but the images were very subpar. I was not able to get good views, basically due to body habitus or clinical status, the patient's moving. And ultimately, the patient still would be assessed a technical fee, because even though these images aren't perfect, what you would consider perfect as the clinician who interprets the images, the bottom line is the machine was still used to go to the bedside, obtain those images. There's a cost associated with that, and therefore we still bill out those technical fees. Now, where this can get confusing is whether you work in a private practice or a freestanding or an outpatient area versus in the hospital. So if you work in the hospital, it's likely that your hospital bills for these technical fees. And this can be inside a facility fee that the patient may get in their bill that's an over-encompassing fee for their visit into the system. But if you are a private practice doctor, say you own your own clinic, it's in the community, there's no radiology or inpatient hospitalization associated with it, you can bill what's called a global fee, which means you can bill the technical portion and the professional portion of your point of care ultrasound. Now, I always think this is interesting because I think we go through a lot of training to become quote unquote professionals, but the money is actually in the technical fees. So when we bill out these studies, we definitely obtain a lot more reimbursement from technical fees than we do from professional fees. So if you are in the private practice world and you are operating independently, billing out those technical fees can be a big portion of your reimbursement. So I'm going to move on to documentation requirements for billing. So anybody who's been doing point of care ultrasound for a while, this probably seems very intuitive that you would create an interpretation, a written interpretation of what you did and put it in the patient's record. But we have rules about how we can bill for this. So the 3 requirements for documentation of your bedside point of care ultrasound include having some sort of written interpretation in the patient's medical record. There's some details about what needs to be included in that, and we'll discuss that in a second. You need to describe the medical necessity of why the ultrasound was performed. So it's very important to have those study indications listed somewhere in the documentation. And then last but not least, and I think many people don't realize this when they're starting a point of care ultrasound program, but you have to be able to permanently store those images and they need to be available for future review. So we can discuss some nuances of that. I'm going to use the American College of Emergency Physicians ultrasound reporting guidelines because this was one of the first groups that came up with a standardized reporting. So these are the recommended reporting guidelines in the emergency medicine community. Many of the other specialties have their own reporting guidelines for what they would require, but this is now pretty standard, and this actually also includes a lot of the components of billing. So you can see that you need to include the patient demographics. This makes sense. You need to include the indication for the exam. Again, this is part of the billing component. Many people will describe the views that they obtained, so which probe they used and where they put the probe on the patient. We need to describe the findings of the ultrasound, which may be different than the interpretation. The interpretation, again, is the way that you interpret the ultrasound at the bedside. And then the ACEP emergency guidelines put in a quality assurance aspect to this. So I think that their guidelines are pretty all-encompassing. I have a QR code and you can pull up that document as needed to look at some of those requirements. Image storage. So do you need it? Yes, you do. If you want to bill, you need to have image retention. It is mandatory for all diagnostic and procedural guidance ultrasound, and that's been in place since 2005. What they don't specify in the CPT code guidelines is how the images are stored. So you need to be able to have these images available for review, but it doesn't necessarily need to be in the EMR. So at my previous job, we had point of care ultrasound and we saved images, but the images at that time we weren't sophisticated enough yet in our IT department to be able to push those images into the patient chart. And we used to have a separate server that was hosted in the emergency medicine administrative offices where all the ultrasounds from the machines were pushed to. And we would do our quality review from a hard drive somewhere in a locked room that was patient protected, obviously, where all of the images were stored. But it didn't change the requirements of what we needed to save to be able to document those images. So we needed to still have some sort of documentable report in the patient's medical record. And when the images went to the hard drive to be saved, we had to have the information to be able to pull up those images, meaning the patient's medical record number and their name and the date that the ultrasound was performed, basic patient identifiers, so that if we were ever asked in the future to be able to pull up that image, we had the ability to do that. Many people who have practiced point of care ultrasound for a long time would remember the days, I trained in the days where we used to print out the paper ultrasound image and tape it to the paper chart. I always find this interesting because I can imagine that any of those images I took many years ago are somewhere in a basement of a hospital. And I suspect that all of the images, like an old Polaroid photograph, have faded and you probably can't see what's on those images any longer. But at the time, that was still the requirement for billing. And so we had our point of care ultrasound machines with a little printer at the bottom. And when we saved images for our trauma fast exams, we would print the images, and with a piece of tape at the end of the chart, when I would sign the chart, I would tape all the ultrasound images to the chart, and we had an extra piece of paper on the back of the chart. Again, the point being is that these images need to be saved somewhere, and they need to be able to be pulled up for review. So here's an example of a typical ultrasound note. I give an example of a right upper quadrant ultrasound that I performed on a patient. And again, you can see that we have all of the main identifiers here. I didn't include this ultrasound report at the top, actually has the patient's name, the MRN, and the date and the time that it was performed. I've obviously cut that image out of this photograph. But you can see that I've listed the exam, I've listed the date and the time that the exam was performed. I ordered the exam and I performed the exams. This is something that you can think about including into your documentation. I have an indication listed here. I have a procedure in detail listed here, so I can describe the probe I used and the images that I obtained, a sagittal and transverse view. And then I described some of the procedure and the images that I obtained while I was doing the procedure. In the conclusion, I have a diagnostic interpretation. So my interpretation here is that there was no evidence of cholecystitis. And then in this exam, I have a comment that the patient had some free fluid. And then I did obviously a separate exam here. Some of the things I'm going to talk about in a little bit that we haven't talked about for documentation is who performed the exam, and I'll talk about that in a little bit. And then I also have something included here which is not required for billing, but I would recommend as we talk about later the difference between a limited and complete ultrasound. We have a statement that says whether a radiology ultrasound was performed, and I'll talk about that in a little bit and why that may be important or something you could consider adding into your documentation workflow. So other considerations for the note, again, one of the things you can consider putting into your documentation workflow is who performed the procedure. Again, many of the places where point of care ultrasound is performed have trainees or mid-levels. And so having a resident or a mid-level perform the ultrasound may be part of your workflow. As the attending physician, you do not necessarily need to be the person obtaining the images, but you do, if you are the billable provider, you do need to be the person interpreting or at least signing off on the interpretation of the images. So therefore, our workflow does recommend that we have who performed the exam and who interpreted the exam or authorized the exam. So we're going to move into a specialized area of point of care ultrasound billing, which is point of care ultrasound guided procedures. So this is different than diagnostic ultrasound, and these are all different codes. And so it's something to think about when you're trying to build your point of care ultrasound workflow. And I'm going to give you a couple of examples that may potentially be missed in your hospital system from billing standpoints. So again, I've got a QR code that has some examples of the point of care ultrasound guided procedural codes. Again, these codes are different. And something you should be thinking about when you're building your workflow is that sometimes we do a diagnostic ultrasound to determine whether we need to do a procedural ultrasound. So the most common example I give of this would be assessing for an abscess. So I go to the bedside and I perform a limited soft tissue ultrasound of the skin to look and see when a patient comes in with, some swelling or some fluctuance. I go to the bedside to determine, is this cellulitis or is this something that's drainable? That in and of itself is a diagnostic procedural CPT code where I'm assessing the area to determine the diagnosis. So let's say I go to the bedside and I interpret that there is an abscess there. Well, then the next step is that I may perform an ultrasound guided procedure of an abscess IND. And if I do that, then there's another procedural code that can be associated with this. Now, over the years, there are certain procedures that they've combined these codes because they're so common, but it's really important that when you are building your documentation workflow, that you make sure that this is delineated correctly so that your coders can get your CPT codes for all of the available studies. So people many times ask about static versus dynamic point of care ultrasound procedures. I'm not going to talk about the clinical aspect of that. I'm going to talk a little bit just about the billing aspect. So you all are fairly aware that static is basically putting an ultrasound on to identify a portion for the procedure. And in this example, it's used for line placement. So you may, if you're looking for an IJ, you may put the ultrasound on the neck, look and see if you can identify the vein. You may say, oh, okay, I know where it is. You may take the ultrasound off, but then you may not use it during the actual procedure of the line. Where dynamic is where you're actually using the ultrasound throughout the procedure to identify the vessel, and you're going to watch the needle enter the vessel under point of care ultrasound guidance. Now, I used to, when I was early in my practice, I always thought we needed to save the dynamic images of the needle going into the vessel, or for example, doing a paracentesis, a dynamic paracentesis. I always thought that that was the case. But it's actually believed that trying to obtain the video image or an image of the needle as it's entering the vessel may pose an unacceptable risk to the patient. And so this is not a requirement for billing. When we teach our physician point of care ultrasound courses for our physicians across multiple emergency departments, they're always very surprised to find out that all they need to save into the system to bill for their point of care ultrasound paracentesis or their point of care ultrasound line guidance is just an image of where they intend to go. And then when they do their procedure note, they can list whether they did it under static or dynamic guidance. So as you're building procedural notes, this is something you may want to consider adding into your procedural notes because it is different. And these CPT codes associated with procedural ultrasound are different. So that kind of also brings us into this concept of limited versus complete exams. So complete exams, as we're all aware, are ultrasound exams where we examine all of the aspects of that particular area. So I'm going to use an ultrasound of the abdomen as an example. So as point of care people, we many times do a limited ultrasound of the abdomen where we look, for example, you saw my previous example of a procedure note where we were looking for right upper quadrant pathology in a patient that came in with right upper quadrant pain. So when we do this exam, we're looking at the gallbladder and we're looking for things like stones and pericholecystic fluid, and we're really examining the gallbladder. But we don't normally examine things like the pancreas, the bowel, the aorta, the liver parenchyma, and that would be considered a complete exam. If you send a patient to radiology for a complete exam, many times they will, in addition to looking at the gallbladder, they will look at the bile ducts and the pancreas and all of the pathology that could potentially be there in the abdomen. And they report out every single abnormality they see. We don't do that. We only bill out for our question, and then we perform this limited ultrasound. These CPT codes are different. So the radiology CPT code for a complete abdominal ultrasound is a different CPT code with a different reimbursement rate than a limited ultrasound. So why does this make a difference? Well, if you are performing a limited ultrasound in the emergency department, and this very rarely happens, but I'll use this as an example. You perform a limited gallbladder ultrasound, and then you decide to do a complete ultrasound where you look at the pancreas and the bowel and the liver texture. Well, you can't do that, and you can't bill out for both exams. So if you're the same provider, you can't bill out for a limited and a complete exam during the same encounter. So the second example, you are an emergency provider, you look at the right upper quadrant, you think you see an abnormality there, and you decide to order a complete ultrasound done by the Department of Radiology. Again, that patient cannot be billed during the same encounter for a limited and a complete exam. Okay, so we have built into our workflow whether an ultrasound was done by radiology to notify our coders and billers to make it easier for them to understand that a complete ultrasound was done and they should just throw out the bill for our limited ultrasound. Again, if you're a patient, that makes sense. Why should you be billed for two separate exams? Now, one last thing is that you could do a limited point of care ultrasound of the right upper quadrant, and then you could determine that you need to order a CT scan. Well, you can still bill out that limited ultrasound because it's not the same modality that was initially performed. So that limited ultrasound can be billed out, the CT scan can be billed out. So those are kind of some nuances of limited versus complete exams. So again, I just want to kind of come back to this idea of focus scans versus extended exams. So we can bill out multiple different types of exams during our visit with the patient, or even over a period of multiple days if the patient's admitted to the hospital. Again, just kind of thinking about some of the ways we can use point of care ultrasound. This is a slide brought from the family practice guidelines. So family practice is one of our newer specialties that is now has some requirements for point of care ultrasound training in their residency programs. They're looking at ways to use point of care ultrasound in the outpatient setting. Again, we've got the physical exam extension, which they are teaching procedural guidance, diagnostic, and then multi-organ scans, right? We are very familiar with these multi-organ scans in terms of patients that are decompensating, where they maybe get a heart exam, a lung exam, a fast exam. And again, many of these exams have different components to them. The reason I bring up this multi-organ scans is just so that you all are aware that many times some of the exams we perform have multiple CPT codes associated with them. So I'm going to give an example of the fast exam. So in the emergency medicine world, we say, oh, we're going to perform a fast exam, right? We're going to look for free fluid. But actually that is, two separate procedure codes. We're billing one procedure code for a limited abdomen and then one procedure code for a limited echo, because one of the portions of the fast exam is to look for free fluid around the heart. If you do an EFAST exam, an extended fast exam, where you add on lung evaluation for in the trauma setting, what we most commonly are looking for is hemothorax or pneumothorax. There's a third CPT code that goes out for a limited chest. And so it's really important that when you're building procedural notes, that you make sure you have all of the documentation required for all three limited studies. So we're kind of getting to the end of the talk here. I know it's a little bit it's dry, but some of the things that we need to think about for special considerations. So number one, do you need to be credentialed to bill? Well, I want to make a very clear distinction that credentialing and privileging is done by the hospital and is not associated with coding and billing. So your hospital system decides if you need to be credentialed in point of care ultrasound to perform these exams. Do you need privileges? What do those privileges require? Do you need training? Do you need documentation or proof that you've done X number of exams over a certain period of time? None of that is associated with billing and coding. If the correct modifiers and documentation and image acquisition is in place, technically you can bill or code for the procedure or the ultrasound. I think this is where it's really important that if you're building a program or you want to know how your billing is going, that you have an open dialogue as a point of care ultrasound person with your billing and coding team. So I very regularly talk to our billers and coders about ultrasound exams performed across our system. We have providers at 14 different emergency departments. And if there's ever a question about whether a ultrasound needs to be billed out, or if there's some sort of question, it comes to me as the point of care ultrasound director to make the final determination of whether an ultrasound should be billed. But that's not necessarily associated with privileging and credentialing. I would recommend that if you're building a billing and coding program for your point of care ultrasound studies, that your billers and coders are aware of who can bill out for their point of care ultrasound. One of the ways that we've tackled this issue, and again, every hospital system may be different, is that we provide every 6 months a list of all of our physicians who can bill and who can bill for certain point of care ultrasound exams. And that list gets updated every 6 months. Therefore, if a physician puts in for an ultrasound exam that they, on the credentialing side, are not privileged to bill out for, our billers and coders, even if the clinician has put the right stuff into the chart, they will not bill that out. So that's, again, one of our ways to stop billing if we don't think somebody has the right credentials to be able to perform an exam. But you don't necessarily need this from a straight coding and billing standpoint. So trainees. Many of the places that we do point of care ultrasound have trainees, and like any other procedure, trainees must be supervised by an attending for billing, because the attending is going to be the one that bills out the CPT code. So if you have these documentation notes in place for your point of care ultrasound, you need to make sure you include a billing attestation statement from the attending. We're very familiar with these, especially if you are supervising trainees that do procedures, where you write a note that says, I personally supervise the key portions of this exam, or I personally supervise the bedside ultrasound. Now, one of the things that you may not feel as instinctual is that you don't necessarily need to be at the bedside with your trainee while they perform the exam. But you do need to review the images and agree with the interpretation that they've put into the chart. So in the emergency medicine world, this is not as much of an issue, because many times our trainees, our whole encounter with the patient happens over a, hopefully not a 12-hour period, hopefully no more than a couple of hours. And so we interact with those trainees at the bedside all the time. And therefore, many times we're at the bedside while they're performing these studies, or in the department to be able to sign off on the images. But let's go back to the inpatient side, where maybe let's look at the intensive care unit, where the attending physician may not be either in-house or maybe in a different area of the hospital, and a trainee, such as a resident or a fellow, may be managing the unit overnight and perform an exam on a patient that has a change in clinical status. It's still a requirement that that physician looks at those images and make sure that the interpretation and the image acquisition is correct. Now, they don't need to be at the bedside while those images were obtained, but they do need to put a billing attestation into the documentation to be able to bill out that point of care ultrasound. Mid-levels. So mid-levels can bill out for 85% of the physician fee schedule for medical and surgical services. So this is the same concept with point of care ultrasound as it is for anything that the mid-levels do. So if your mid-levels, and again, this goes back to credentialing and privileging, let's say you've got a group of mid-levels who you've trained and who you feel comfortable with their point of care ultrasound, they can actually bill it out under their own provider number if their provider number is under the shared visit guidelines able to be done. So it can get a little complicated here. So let's give a couple of different examples. So let's say that I am working with a PA in the emergency department and the PA performs the point of care ultrasound and we see the patient together and I sign off on the whole encounter. So that CPT code would come to me as the attending provider and I would bill out that CPT code under my NPI number. But let's say, second scenario, we have a split flow / fast track / urgent care type area. And let's say the PA operates independently in that area. Well, if it's not under a shared visit guideline and the PA is, per your hospital system, allowed to do point of care ultrasound, they can bill out that CPT code under at the same rate, only that they would retain 85% of the reimbursement of the study that was done. Same with NPs. Again, they can do the same thing. Now, what happens if you're an NP and you're working in an outpatient facility and you don't have direct physician supervision? So you are in a family practice office or an internal medicine office and you decide to do a limited DVT study and the machine is not owned by the system and it's just a private practice office. Well, that mid-level can bill out the CPT code and they can bill out the professional and the technical fees for that CPT code. If they're in a hospital system and the machines are owned by the system, then they can bill out the professional portion of that code. So that's kind of a whirlwind on billing and coding. I'm happy at this time to take any questions you may have.